na tu yenye ulituma uliforward hii hapa. Si amejoin. Si nimetuma na join. Kiangalia huko juu.
Hi, everyone. Thanks for joining us this afternoon. We're going to get started in just 2 minutes. We do like to keep our briefings to 1 hour, so we will get started in 2 minutes as we let other people in from the waiting room. And thanks for joining us today. Good afternoon, everyone. My name is Jessica Gorham, and I'm the Regional Emergency GBV Advisor working on behalf of the GBV Area of Responsibility, which is the global coordination mechanism for gender-based violence in emergencies. But today, I am also here in my role as the co-chair, along with CARE International. We are the co-chair of the Regional GBV Working Group for East and Southern Africa. And throughout the month and the year, we like to organize briefings and also other types of webinars and learning events on behalf of our members and to the greater community. So we're really pleased today to be hosting a humanitarian briefing on coordination of gender-based violence services in conflict and drought-affected communities in Ethiopia. Many of you might have participated in some of our previous briefings on Somalia and cash and voucher assistance, for instance. We've also hosted many others on Ethiopia, Mozambique, South Sudan, and various other topics. So thanks for joining us today. As usual, we will have everyone on mute throughout the During the Q&A session, I will be presenting like questions to our presenters. We find that this cuts down on the amount of time it takes for us to go through the Q&A, since there are like questions throughout. So please, if you could make sure that you write your questions in the chat. We will be able to provide a recording of this session and also the PowerPoint presentations on gbvaor.net. We will post them usually within the week of our webinars. So please don't hesitate to reach out and go to gbvaor.net for a copy of the presentation and also for a link to the recording. I'm really excited today to introduce our speakers. We have both of our GBV sub-cluster coordinators joining us from Ethiopia. Ephraim Karanja is the National GBV Coordinator for gender-based violence in gender-based violence and emergencies in Ethiopia. And we also have Chacha Masori, who is the GBV sub-cluster coordinator in Tigray. And we are also joined by one of our implementing partners, an active member of our GBV subcluster in Tigray, Ami Kande, who is working on behalf of UNICEF. So again, thank you all for joining us today. Please note that Ami is joining us from Tigray. So if there is a connection problem, Chacha will be able to step in. But we're really hoping, Ami, that we'll be able to keep the connection with you. Since we do have various types of connections, if we could ask everyone to please put their cameras off. And then, as I said, you'll be on mute throughout. So please don't hesitate to write any questions you might have in the chat, and I will be monitoring throughout. And as usual, we will keep this to 1 hour. So without further ado, I'd like to hand over to my colleagues, Karanja and Chacha, who are in Ethiopia and coordinators on behalf of our partners. Over to you, Karanja and Chacha.
Thank you very much, Jessica, and good afternoon, colleagues. Very much welcome to this briefing. We hope that it will shed light on the work we have been doing, as well as the situation as it is in Ethiopia, both on the conflict side, as well as the issue of the drought affecting the southern regions of the country. So if we can go to the next slide, please. Since we are at the start of the year, I would like to start with the snapshot of our 2021 results. And with this, we covered most of the areas of the country, with a lot of coverage being the side of Tigray due to the conflict. And that's where we have most of our partners are concentrated. However, when you look at some of the other areas like Benishal Gumuz, Gabela, Somali, which is quite huge, we didn't have a lot of coverage in terms of partners. So our PIN for last year was 3.5 million, where we targeted 1.1 million and reached approximately 760,000 persons. We were active in almost all regions. However, we were only able to reach 20% of the warriors that were targeted within the response. For implementing partners, we had 56 last year by the ED, mainly international organizations. Next, please. So for 2022, the people in need for GBV response has increased to 5.8. And this is due to the different issues, and especially the conflict in the north affecting Tigray, Afar, and Amhara, which has led to quite a huge number of people affected, including displacement, etc. And also the fact that a lot of the people affected are still within their communities and have not moved. For the target, we are targeting 2.2 million people across the country, and this is an increase of 100% from the 1.1 million we were targeting last year. So the escalation in the north, as I said earlier, has led to quite a huge increase in levels of GBV, and especially across Tigray, Amhara, and Afar. And from the reports of the different bureaus, there is quite a high number of sexual violence cases reported or seeking services within those areas. We also have huge needs in areas of, for example, Benishal Gumuz, Somali, Oromia, SNNP, as well as the new region, Southwest region, due to conflict and drought. And some of these areas suffer from sort of a complex situation where you have the conflict and also you have the drought on top of that. Some areas are quite challenging in access, for example, Benishal Gumuz, because of there's quite a huge huge presence of armed groups, and this makes it very tricky for aid workers to be able to access some of the communities. One of the response modalities that is quite strong in Ethiopia is the one-stop centers. And currently, from our mapping, there is 45 one-stop centers spread across the country. The other thing to note is that around December towards January, February, there has been improved ease of access to Tigray for supplies. Also cash as well as staff moving in. We have flights twice a week. And also the road is open, only that there is some conflict issues. But if that is sorted, then goods will be able to move by road also to the region. Looking at the drought situation, which was mapped recently, we have 124 warredas in the southern part of Ethiopia, that is in Somali, Oromia, SNNP, and southwest regions affected by the drought. And this we can see in the map in the next slide, please. Yeah, so I know the conversation focuses more on the drought in the Somali region, but when you look at the map, it's quite bigger than that. For example, in Oromia, you have 36 warredas affected by the drought. Of course, Somali is more affected than the other regions, but the spread is quite huge across the southern part of Ethiopia. Next, please. So when you look at the drivers of GBV in the country, maybe one first to mention is that even without the different emergencies, the levels of GBV from the DHS is quite high. But however, now when you put in conflict, we have seen that there are quite high risk, especially for sexual violence for women and girls. There is, for example, in the northern part, there was quite a disruption of core GBV services. The referrals were affected and hotlines were affected because of cut in communications. At the same time, there was inaccessibility to available services for affected populations due to the conflict, because it was quite for some time. And also there is inaccessibility by aid workers due to presence of armed groups or ongoing conflict. This is especially in the regions of Benishal Gumuz, parts of Tigray, the northern part and the northwestern, parts of SNNP and parts of Oromia. When we look at now displacement, with the conflict, we have had a lot of displacement, especially in Tigray and Amhara. And with this, we have seen women and girls being exposed to survival sex and share risks due to lack of access to aid and resources. This was quite a huge problem in Tigray because from around July, there was sort of a restricted movement of goods and supplies to the region. Overcrowding in common shelters and a lack of segregated facilities has also been seen to expose women to sexual violence. This has been reported in the different reports, interagency reports, as well as from partners, especially in areas hosting IDPs in, for example, in Mekele, and the same for Amhara, since most of the areas are not really IDP camps. It's IDPs congregating in abandoned factories or other buildings. There has also been a lack of response services and basic commodities that is consumerate to the displacement. We don't have enough data kits, for example. The safe shelter is limited. There is a lack of NFIs, and this also increases the risks as well as the effects of GBV. When we look at the drought situation, women and girls are exposed to survival sex and sexual and exploitation and abuse risks due to lack of access to resources. This has been reported from the recent protection assessment done in Somali region. At the same time, as women and girls travel outside their community for livelihood activities, fetching water, firewood, etc., they get also exposed to sexual violence risks or attacks. We also see a rise in a risk of early marriage for girls, as well as a possible rise in the domestic violence due to diminishing household resources and income across the affected regions. Next slide, please. So for 2022, the need as per the draft HLP is, or the ask for the AOR for 2022 as per the draft HRP is 89 million. This is quite a huge ask, but it's informed by the huge needs that we have in the country. For this, we are looking at scaling up the response of GBV through the one-stop centers, increase in women and girls-friendly spaces. We are looking at strengthening GBV referral pathways through comprehensive GBV service mapping. And later on, we'll see the pilot that we have carried out in Tigray, which we plan to strengthen across the country. We're also looking at having more community GBV awareness, also trying to work on issues to do with stigma, which we have seen as a huge impediment in survivors seeking services. And for example, we have seen that majority of survivors sought services almost when they are pregnant or when they have an illness caused by for example, sexual violence. We're also looking at distribution of especially for the IDPs, strengthening coordination mechanisms across the regions, capacity building of frontline service providers, which is a huge need. And this is given that we have a gap in provision of core GBV services, especially case management. We are also looking at livelihood programming for vulnerable women and girls. This is both to mitigate negative coping mechanisms as well as supporting reintegration for displaced women and girls. We are also looking at GBV mainstreaming across the humanitarian response, as well as establishing GBV standard operating procedures, strengthening GBV MS, and also having GBV assessments to inform programming and trade. Next slide, please. So from our dashboard, this is the ongoing response as of February 2022. And if we look at the part of, and this link will be shared so that you can be able to interact with it and be able to see how we are doing. However, just to highlight that, for example, when we look at implementing partners per region, we see that there are regions that have very few partners, for example, Benishal Gumuz and Somali. And when we look at even implementing partners by type, we also have a huge number of our partners being INGOs. However, we are in discussions with the different local mechanisms. We have the CSSSP that is working with national organizations and civil societies. We're also in discussion with NEWA, who work with local women-led organizations to see how we can bring them on board within the humanitarian response. And then we can be able to work with them to strengthen the response, especially within the hard-to-reach areas whereby they are already providing services, but they are not captured in our response here. If we can go to the next slide, please. If we look at the number of implementing partners by GBV activity, and this is something that I had mentioned earlier. If we look at GBV case management, Currently, as of February, we have 4 partners reporting on working on GBV case management, which is one of our very core activities. We have more partners working on GBV awareness raising. We have PSS, a lot of partners working on PSS, which is most likely the community-based PSS or psychosocial support, and also a lot of partners working on the kits. So we are looking at how do we strengthen the delivery of core GBV services, including strong psychosocial support or individual counseling, as well as case management. And so we are looking forward to having the case management capacity building initiative rolled out within the year, dependent on resources availability. If we can go to the next slide, please. So these are our donors and partners as of February. We have quite a high number of donors, but maybe also to mention is that when we look at the donors vis-a-vis the regions they are supporting and partners, we also feel that there is quite a huge number of partners who are not reporting on their funding or on their activities. So if we look at, we have 17 donors, and then we have 27 implementing partners. The ratio is quite a bit not balanced. At the same time, we also have what I would say, I know there are quite a number of donors that are supporting through what I would call multi-sectoral programming, whereby you have, for example, funding through within a project or within the health sector. So that is not necessarily being reported. The GBV response in that may not be reported within the GBV AOR, and it goes more to be seen as a health response. Next slide, please. I mentioned that earlier that we have one-stop centers as a core GBV response in the country. This is the distribution of where we have the one-stop centers. Currently, Oromia leads with a number. They have 18. Whereas when you look at Somali, for example, you have 2. In Amhara, which is quite highly affected, we have 3. One of the in the response plan for Amhara, increasing the number of one-stop centers or integrated response centers is high in their need for support. If I can highlight some of the support we have had for when it comes to one-stop centers, is that we have, for example, the renovations being done, and this has been supported by different agencies, UNFPA, UNICEF, ICRC. Then when you come to capacity building, we have WHO and UNFPA leading in capacity building, especially on clinical management of rape. Then we have supplies, different agencies, including UNICEF, UNFPA, ICRC, and this includes medication or medical supplies, as well as the furniture and other materials. In terms of, for example, deployment of support staff, we have different agencies supporting, especially UNICEF and UNFPA, in supplementing with psychosocial support staff, social workers, counselors, as well as nurses. If we can go to the next slide, please. I will have Chacha take over from here, and he will cover the next 2 slides. Over to you, Chacha.
Thank you. Colleagues, good afternoon. I hope you can hear me. Of Dr. Karanja, having given a great overview of what is going on in the response, we have taken this opportunity now to look at the response gaps, constraints, and challenges. Essentially, insufficient funding remains a considerable challenge, comparing this to the needs with some of the areas extremely underfunded. As you may have seen in the snapshot, the geographical distribution of the partners is commensurate with the funding, and therefore in areas where we have very minimal partners are actually also quite significantly underfunded in terms of response. And these are the Benishal Gumuz, SNNPR, Oromia, and Somali regions, but also even within the areas with considerable funding, there are specific Wareda, which if you go into the details, you realize that the funding might be very concentrated in specific areas and other areas are largely uncovered. So this is an insignificant gap. Insufficient presence of GBV partners to offer core GBV response services, especially in hard to reach areas. As you know, the presence of partners and the distribution has been mostly because of the conflict, and the drought just came into the picture. And as you can see later, we have actually the areas which have only conflict, there are areas which have drought, and there are areas which have both conflict and drought. And therefore, the insufficiency of presence of the GBV partners to offer core GBV services is actually a concern that is making it a challenge to respond adequately. Disruption of GBV response infrastructure because of the conflict, institutional structures and support mechanisms having been destroyed, having been looted, and largely the absence of humanitarian as well as the traditional institutional staff who have been working in these areas prior to the conflict has also resulted in actually the disruption of this GBV response infrastructure and services. Presence of armed groups across conflict-affected regions. This continues to hamper access to both affected populations and humanitarians. And just very quickly, colleagues, it's important to note that the conflict is so dynamic in the sense that there are areas which are basically pitting different levels of conflict, looking at the formal military, the areas where we have conflict related to intertribal clashes. There are conflicts related to clashes between the pastoralist communities over water and pasture. So essentially, the fluidity of the conflict and the diversity of the belligerents or the people, the groups involved, is making it quite complicated in terms of mapping presence of armed groups across the conflict-affected regions. But then this continues to hamper access to both affected population and humanitarians, because as others run away from the formal military engagements, other areas we have issues related to the non-military related belligerents. So this is a quite considerable situation. Desperate living conditions in displacement areas exposing women and girls to survival sex, as well as other vulnerabilities generally in terms of the increasing number of female-headed households, the fact that men have traditionally been household breadwinners of the families, and now they are actually either conscripted into war, they are injured, or they actually dead as a result of the conflict. So you find that this is increasing the burden on the women, and therefore they have to do anything necessary to keep their families afloat. So the conditions of living are really getting difficult. Missing of the farming windows last year because of displacement, missing of staying in IDP locations where they have no formal income, they have lost household economies. So essentially, these are really conditions that are driving the population into desperate living conditions. The low number of partners providing comprehensive range of GBV response. As we said up, there is, of course, insufficient presence, but additionally, there is the numbers of the comprehensive package, the minimum package that you can say with this kind of minimum package, you are able to provide at least a good quality service. Again, majority or a good number of partners are offering one or the other type of service, and the ones providing, the comprehensive, list according to the minimum standards are quite few, and therefore, again, there might be services somewhere, but they are not necessarily comprehensive enough to meet the needs of the survivors across the continuum of care. Gaps in coordination in some regions and weak mapping of services, and thus lack of localized referral pathways. Again, as we said, as a quick example, the conflict areas seem to have some better situation when it comes to the mapping and presence of coordination. But the drought is an additional driver that has come in quite recently, and still efforts are underway to try and do the service mapping, do the partner presence mapping, develop referral pathways for these particular areas. So a lot of this is actually work in progress, but the gaps actually largely remain because, again, being an emergency, it's not easy to determine how and how long the conflict or the drought is going to take for us to be able to move, but we are moving all the same with the minimal resources that are at our disposal. Challenges in GBV data information management, lack of data collection systems, including the GBV IMS, challenging informing of trends. Essentially, as a significant number of you may already know, is that the systems around data safety, the collection, the ethics around data, these have actually been significantly affected by the conflict, by the displacement, the breakdown of institutions that would support this kind of safe data handling, safe data collection and storage, security, among other issues related to ethics. So essentially, the conversation at the moment is tending towards having GBV IMS rolled out additionally into the areas that the conflict has spread to, into the areas where the drought has spread to. So again, another work in progress, and therefore the challenges remain. Next slide, colleagues. Allow me to turn into the key asks because I know we will have an opportunity to possibly have conversations around the questions and clarifications on some of this. But the key asks for us as a context start with prioritizing GBV in the humanitarian response with a focus on core GBV services. And here we are looking at the entire continuum, looking at health, case management, psychosocial support, legal aid, safety and security. And therefore, this would also satisfy the multi-sectoral approach, satisfy the multi-level approach in order for us to be able to have a response that is really offering adequate services as necessary for the survivors through the continuum of care. Ensuring integration and mainstreaming within other sectoral interventions, informed by a robust sectoral GBV and gender analysis. Again, calling upon each one of us, depending on which level, depending on which area of intervention we come in, to put effort towards ensuring that integration and mainstreaming is a core area to ensure that as survivors and as beneficiaries take advantage of the various sectoral services, they are also able to enjoy the considerations that ensure that they are not at risk of GBV, sexual exploitation and abuse, and they are able to really receive the consumerate services or be referred to the necessary services. Ensuring adequate funding for GBV in the response plan, as well as longer term funding for sustainability linked to the humanitarian development and peace nexus. Essentially, colleagues, as we have learned from other contexts and have learned from other conflicts, conflict starts but doesn't always end very easily and very quickly. So already starting to build our systems, build our planning, build our thoughts around the nexus and the recovery, so that we ensure that as we move forward and as the situation continues to be fluid, even in those areas where the conflict and drought has not arrived, already systems are being strengthened to absorb the possibility that if any spread happens, then those areas are able to absorb the new pressures around the increasing need for services. Investment in livelihood interventions for women and girls to address negative coping mechanisms. As we have said, colleagues, earlier, there is a very big number and a very significant population that has lost their household economy, have lost their livelihoods, have been displaced more straight into the internally displaced camps, have moved to live among relatives and host communities, and have significantly just lost their livelihoods, and they are unable to know even where to start. So essentially starting to rebuild this to help recovery, starting to look at how best they can be supported to start picking up again on their lives moving forward. But also looking at families, if they have alternatives, then you will essentially be also addressing the other negative practices like child marriages, survivor sex, and of course, you also support reintegration of GBV survivors into their communities. Investment in capacity building of frontline service providers. Again, as I said, this is a country with a very big population. The needs are very huge. The needs are quite widely spread, and therefore the need for capacity building, the need for frontline providers in terms of numbers, in terms of their capacity to respond, the fact that a significant number of them have been working in a development setting. So the humanitarian context is basically a new area. So really bringing them up to speed to respond in line with the needs of humanitarian settings is actually a need that has remained quite significant. And also we are looking at areas that are not necessarily in conflict or drought now, but they're living with the fact that potentially these areas could very easily become front lines before we know it. More support for GBV coordination and strengthening of GBV information management. As I have said, data is a big concern for us. Not necessarily the management, but also right from the systems to collect the data, systems to ensure that the data is safe, systems to ensure that the ethics around the safety of the data and management and handling is actually taken care of, the possibility that we can develop trends, the possibility that we can use this information and data for decision making and planning. This is an area that needs significant support. So we are looking forward to help in this area as well as one of our asks. And of course, last but not least, there is the issue of more advocacy on GBV issues at all levels, essentially looking at the donor community. As you engage at your level, please consider having the conversation, having the GBV issues put on top of the agenda so that we can really have consistent and considerable support for the women and girls in this country. Looking at the various policy makers, that engagement is also important to ensure that the systems, the landscape is covered with adequate policy level requirements that to ensure that the services are really well cushioned in order to ensure that they can continue remaining available for the communities and for the women and girls who need it. Looking at the public sector, the private sector, looking at the authorities and the owners of the decisions, also supporting and engaging them to ensure that we can have advocacy that puts in the forefront, puts on top of the agenda GBV issues so that we can be able to adequately respond. Colleagues, allow me to request the next slide and invite Amy to do the final 2 slides, and then we should be okay.
Great, thanks, Chacha. I mean, we have, we're a little bit over time. If we could take about 5 to 8 minutes to provide an overview of the mapping that was done, the exercise, that would be appreciated, so that we have time for questions as well.
Yes, that would be great, Jessica. Many thanks.
Yeah, thank you. And my colleague Shiva is sharing the second presentation, which will be given by Ami. And if, as I said, if you could keep it to 5 to 7 minutes, that would be appreciated. Thank you, and over to you.
Hello.
Hi, we can hear you well.
Yeah, this is just to give you a quick snapshot of the collaborative work that was done by the Tigray GBV AOR in compiling Tigray GBV service mapping in order to facilitate access to minimum GBV standards. So basically, the essence of this was to basically understand who is working on site and what they're doing, and then to be able to provide a comprehensive directory that will actually let all partners know who is providing services and where. Can I request the next slide, please? Hello?
Yes, it's been
Yes.
moved forward. We're on locations targeted.
Okay, so in terms of really the location, as you might be aware, there is still active war in the Western zone. So out of the 7 zones in Mekelle, in Tigray, we are able to actually undertake service mapping in 6 of those: Mekelle, Eastern, Central, Northwestern, Southern, and Southeast. So those were the areas we are able to undertake. And the results are, can you move to the next slide, please? So basically, in terms of the service, what the mapping highlighted was that there is low coverage in terms of services within the area of Tigray. So out of the 88 warriors that are accessible in terms of services, there were only 37 functional in 37 of those. So, and out of those 37, there are only 21 institutions that are providing services in health, psychosocial, case management support, legal and justice, security, and safe homes. Then out of those, you have 39 that are providing health facilities, health services, of which 31 of those are government facilities. Out of those facilities that are providing health services, 21 are actually providing comprehensive post-rape care for adults and children, with the remaining 69 really providing just partial care. Then 10 of those institutions are primarily focused on psychosocial support and case management services. Then out of the mapping, one thing that we actually highlighted, it highlighted that coordination is very weak. That is something that is very highlighted. Then the other thing that it highlighted again is that from the mapping that a lot of partners are now concentrating actually in terms of know-how how to deal with conflict-related sexual violence. That is something that is lacking. Then there is limited capacity, and most of the capacity on the ground has always just focused on training. So those are the things that it find out. Next slide, please. In terms of recommendations, what are being recommended is that, next slide, please. So in terms of recommendation, what is being recommended in moving forward, that services should be upscaled so that coverages actually could be the whole of Tigray. When the Western zone opens, there will be, that's somewhere that we need to upscale to ensure that services are increased. Then we need to build capacity around handling of conflict-related sexual violence and to make sure that that is tailored according to the needs, because what we are finding out is that partners are doing something different. Then in terms of the packages for healthcare services, these are the highlighted. So mainly the 39 partners, these are the packages that they are providing. Then in terms of recommendation, we're looking at scaling up GBV services based on the mapping finding. Then we should be looking at looking at comprehensive, looking at developing a comprehensive GBV directory, because as of now, the Western zone is missing. We need to raise more awareness on the availability of services and ensure that the referral pathway is working as well. then we need to actually look at developing and implementing together as other GBV partners, comprehensive capacity building for GBV specialists and non-GBV specialists. They're really looking at increasing GBV risk mitigation across programs, clusters, and communities. Thank you.
Thank you. I mean, that was very quick, which I appreciated, but also I think you had lots of good information still to share. I mean, where can they find the report on?
The GBV service report, I'm referring you back to Chacha.
Jessica, if I can come in, we have uploaded the mapping report as well as other referral mechanisms within the humanitarian response info, so that all partners can be able to access. That is for any partner working in any of the regions that has an updated service mapping or a referral mechanism. Over.
I think Jessica has some connection issues. If Ephraim and Chacha, you can continue, or maybe by taking questions.
Okay, Shiva, I think I can start with responding to questions. I noted the questions are down. I'll start with one on the GBV and CP AOR separation. As most people may be aware, we work jointly as a CP GBV AOR coordinated mechanism. We have had quite a number of discussions around it. Currently, we have it at the SAG level, and then we'll move it to the principals depending on the decisions that we make. At the same time, for GBVOR, this has been discussed extensively with the principal, that is the UNFPA representative, and yeah. So once we are in agreement, we should have the separate coordination mechanisms. If I go to the next question, there was a question on the perpetrators. Oh, Jessica, you are back. You can lead the discussion. Jessica?
Yeah, I'll put those, I saw, can you hear me? Can you?
Yes. Jessica, should we continue or wait for you to lead the question part?
You hear me, Karanja? Hello?
Yes,
okay,
though your
great.
internet is
so I'm going to put some of those questions. Chacha?
We can hear you, but you have some issues on your connection. So, but we can
Can you hear
now.
me now?
Yes.
Okay, I've switched over to another connection. So, but if I go out again, please do just continue because we're taking up valuable minutes. If I'm able to be heard now, I'm going to put some questions together about one-stop centers. And we had a lot of questions actually in terms of first, where people are interested in where they can find the specific locations of one-stop centers and also the services that are provided in each of those centers. Is there a repository where someone can go to find that information, Karanja?
Yes. We have started, we have embarked on the mapping of the one-stop centers. What we have forgotten now is the numbers and the locations. So we already have a map that I can display later that shows where physically these one-stop centers are. In terms of services, it differs from different one-stop center to the, or from region to region, and especially, for example, for the northern Ethiopia response part, except I think for the Aida hospital, which was quite strong, and so it has sort of a comprehensive service package. The rest were affected, and most likely you'd find, for example, the health part response or the psychosocial support, but the legal justice and the police is absent because those structures were affected in the region. In the same case for some of the, in Amhara, some of them have also been run down, and so they have huge gaps. Also, when it comes to the availability of space, yeah.
Oops, sorry. Just quickly, is there a place where they can go and look and identify specific, I think that's what they're specifically looking for. If you have a link to that mapping, can you put it in the chat, or we can provide it when we send out the materials? You had mentioned there is a map, and then does that mapping include the specific services that are provided at each of those one-stop centers? Is that a yes or no?
That is Jessica. This is Chacha and colleagues. That is a yes.
Okay, great.
One from the Tigray service mapping. There is additionally a directory that was produced from the service mapping findings that details each of the services and what is the range of services available for each of them. And then, of course, secondly, as Karanja was saying, the link will be provided, but it is work in progress because it's pulling together data from the different regions, including the Tigray one, to be able to have a complete link where one can find all this information in one stop. Yeah.
Perfect. Thank you, Chacha and Karanja. I think that's exactly what they were looking for. And so we'll either be able to link you to that resource after the webinar, or we'll give you a time frame in which they expect it to be completed. Just to close out questions about the one-stop centers, we had a couple of questions wondering whether you are also assessing the quality, because Karanja, you mentioned they're at different levels. Is there a protocols in place or processes to measure the quality of those services at OSCs? And also, because of the conflict, are you looking into also instituting or implementing mobile one-stop centers? Because you mentioned that accessibility in some areas due to various reasons is an issue. So the first is about, are we assessing quality? The second is, are we thinking about mobile one-stop centers in those areas that currently do not have services? Over.
One, on the quality of services, as I said earlier, we have gaps in some areas dependent on what is affected by the conflict. For example, where, as I said earlier, in the northern Ethiopia crisis, some areas don't have police or the justice mechanism. It's in mainly the medical and psychosocial support that's available. We are in the process of mapping the quality of service as well as the needs, and how to strengthen the one-stop centers across the country. Secondly, if I may add, is that on the static versus the mobile ones, the static ones have been a very crucial or important in the response. This is where most of the cases have been seeking services. However, we have integrated GBV response into the mobile health and nutrition teams within the country, and this also supporting the GBV response. Lastly, we have UNICEF is supporting in the development of the SOPs for one-stop centers. And for the Tigray response, we just concluded supporting them in the revision of their register as part of the ongoing support that is there. So maybe also to add is that the one-stop centers were not established within the emergency response. They are from the development part of GBV response, and they have been increased within, for example, in Tigray due to the crisis. And in Amhara, there are plans now to increase the number. So this is a lot of this can also be linked to the question on the humanitarian development peace nexus that was there, and this is one of the areas we can say the connection is quite visible. Over.
And Karanja, just because you mentioned this terms of quality, is there a mechanism to also seek feedback from users? So the survivors or those at risk who are using services, have partners or the AOR been putting in place mechanisms to look at user friendliness or user satisfaction in terms of services? That was a question by, I think, another one of our colleagues, Fred, if I'm not mistaken. Go ahead. Karanja?
Not yet, but it's something that we are working on in looking at, and it will also be included in the SOPs being developed. So it's work in progress. Yeah.
Okay, so just note there's also interest around that. I have a couple questions coming together about case management, and I'm going to add Ashley's last question around this as well. We noticed that you said there were only 4 partners who are currently doing case management. And how are you prioritizing the expansion of this? Are we looking into local-based organizations or others? And I'm going to add this to the last question that was just asked. And this is around, because we have so many partners, the majority of our partners are really focusing on GBV awareness raising. So we're raising awareness, but we don't necessarily have the partners who can actually provide the service once the awareness is raised. So what are we doing in terms of equalizing those numbers? Are we looking at more local organizations that can transition into doing more case management? Is there a strategy in place? Over to you, Karanja.
What I would say is that it's quite also for us, it's quite a bit frustrating because this is should be our core response area. So what we are doing is, for example, and this also goes to our ask, is ensuring that GBV actors are providing the continuum of services that is needed, and are not focusing on the soft areas of awareness or digital kits. So, for example, when it comes to EHF funding, the core services is one of the areas we are ensuring that is included. When we come to the case management, we have plans to roll out the capacity building initiative that is focuses on case management. And apart from that, these are also a discussion we are going to have with partners to really understand what challenges they are facing in this. Also looking at how we can have more of the partners working on a psychosocial support, embrace case management as a response modality. So yes, and this is also linked to the issue of having the GBV IMS discussion in the country, which we have already started. We had this discussion. We have had this discussion with the global colleagues twice, and also we had the discussion in the GBV AOR retreat in December, and as well as with our government counterparts at the ministry, and they are supportive of us rolling out the GBV IMS.
Okay,
Over to you, Jessica.
Thanks, Karanja, because I know our colleague from the World Bank had a specific question about rolling out the GBV IMS. So based on what you have just said, it sounds like, because it's not a decision necessarily of Karanja or Chacha or UNFPA, it's a decision of the members, since it's an interagency collaboration. Based on what was discussed at the retreat, the members are keen to see the IMS. The government is also keen to see the IMS rolled out. And I understand that it might take a bit longer for this to happen because of some of the security issues involved in terms of making sure the protocols, we can't roll out the GBV IMS unless there are clear protocols for data protection. Is that correct, Karanja?
Yes, it is, and I think one of the issues we are trying to address is the sensitivities that were there in the previous conversation around the issue. Like I think 2 years ago, on the government role in the GBVMS, and so once with this we have a clear agreement on this, I think we'll be able to move forward. If this is not resolved, then we may have the same challenge as was there previously.
Okay.
Over to you, Jessica.
And we have, thanks, Karanja. We have 2 minutes left. And I noticed that a few partners have just said that they saw what they think are discrepancies on the GBV the AOR dashboard in terms of partner presence. And I wrote in the chat, but maybe you also want to reiterate that the dashboard reflects those agencies who consistently report on the 5 Ws, which are sent out basically a few times a month to be updated. So we can't report if those partners don't contribute to the 5 Ws, which is another reason there's such an important tool that you don't realize perhaps the impact. But Karanja, maybe you could say a little bit more about that, because I know we had some that said some partners are not reflected on that, and some of the services are not reflected. Like there are more IPs doing case management than just for instance.
Yes, and I agree with that. And one of the challenges we have is that partners, and I had said it earlier, partners are not reporting very well on the 5 Ws. And that also is why I also say that when you look at the ratio of partners vis-a-vis the donors, we should be having more partners reporting and more areas covered and better results. So, so for us, we would encourage donors to really push on their partners to participate in the coordination mechanisms, including the 5 Ws, because these showcases what we are doing, and it's able to give a clear picture of where we are. And it's also very important for coordination. Maybe what to add is that we are also improving on the 5 Ws tool. So in March, we are going to roll out a new tool that is expanded to cover more services, and it is in line with the current HRP framework. And lastly is that once that is done, then we'll have this dashboard live online, whereby it is accessible, and partners can be able to ask questions, and also donors can be able to ask questions if they are funding a partner in a certain area and that is not reflected in the dashboard. Over to you, Jessica.
Thanks, Karanja. So really good recommendations here. If you're a donor who's on the call today and you're not seeing some of the activities or partners that you fund, then there's most likely a discrepancy in terms of reporting. So it's also, if we get from both ends, in really encouraging partners to feed into the 5 Ws, it does give us a much clearer picture of what's going on. I also think this, when we look at some of the gaps in some of these areas that we're trying to scale up in, it also really highlights the need to prioritize funding for coordination. Because coordination, this is a product of strong coordination. And you can see in areas where we have full-time staff and where we also have IM, we're able to provide more information, full stop. That's exactly how it works. And in some of these drought affected areas where you see we have less presence, less partners, or maybe more local partners that just don't know how to access some of these services or some of these advocacy tools, again, it really reflects on the need for us to ensure that we have strengthened coordination as part of our scale up as well. So last question, Karanja, because we are now 3 minutes over, which I apologize, but I think we will stop with this last question. And that is, we had a few questions around that. I'm going to put those into one. So we have now, there's in some senses, a truce has been called. We know that from the mapping that Ami had spoke about, that there's a need to scale up in the western part. and we're going to be scaling up in other parts throughout drought affected areas. How is the GBV subcluster in Ethiopia going about this? Is there a strategy in place for scale up? What's the discussion in the AOR forums? This is our last question, Karanja. A big one, I realize.
Yes, on this, in our HRP framework, we were aware that these are areas that are keep on shifting, and so they are part of our response. So the fact that they were inaccessible, we didn't leave them out in the response plan. So in the HRP response plan, this part of all these areas are included. However, even with the truth, we have to consider that, for example, the northwestern Tigray is now like a disputed community area. It's not more on the conflict, the national level conflict. And so in some of the other areas that are affected by intercommunal conflict, like in Benishal Gumuz, some areas of SNNP, the areas, so I would say the experience is quite fluid. And so for us, for example, we are hoping that with the truth, then we'll be able to expand to areas whereby then the conflict was preventing us from going to, and especially, for example, in Afar, the border between Tigray and Afar. However, for some areas, even with the truth, maybe we may still have challenges. I invite Chacha to add.
Jessica, just quickly, so in the interest of time, your question was also on a part of the strategy. Two things have happened. One, the fact that in the HRP, we took cognizance of the fluidity of the situation and the possibility that the conflict may or may not spread, but also looking at informed by the access maps. That's one. But secondly, there is, alongside the OCHA coordination hubs, which have now expanded to 6 throughout the northern response. The coordination mechanisms are being set up in all those areas and in some of the prime subnational locations where additional workload is seen, to include partners and include more IDPs moving there, but also absorbing both the tribal level displacement as well as the continued displacement and returns that are happening as a result of the sporadic return to normalcy in some of those areas. So of course there is the expansion, the scale up, but as well as continued monitoring closely of the situation to ensure that we are able to respond rather than react when the situation is worse. Over to you, colleagues. Many thanks.
Thank you, Chacha. I think we'll end here because I do want to make sure that we maintain time. One of the hallmarks of coordination. So thank you to both Karanja and Chacha, who are representing the GBV subcluster in Ethiopia, 2 of our subcluster coordinators, and then also to Ami, who is working on behalf of UNICEF in Tigray. Thank you for taking the time for joining us today, especially under such complex circumstances. We do really appreciate all of you joining us today. And I think you can see that people are really keen to get a lot information on the context and on the way forward. So we're looking forward to scheduling more of these in the future, because I think we don't want to be overshadowed by happenings in other parts of the world. Especially we want to make sure that that Ethiopia still remains a priority, not only at regional level, but also at global level. And this is a way that we can do that. So thank you all for joining us today. We hope the Regional GBV Working Group for East and Southern Africa hopes to have our next briefing on Madagascar. We will be sending out invitations on that. As you know, we're lots of scale up going on in Madagascar, and we're wondering how we can be more influential and advocate on behalf of our partners there. So thanks again to Karanja, Emmy, and Chacha for your participation, and thanks on behalf of the Regional GBV Working Group for East and Southern Africa, both from the GBV AOR and my co-chair, CARE International. Please do join us for any future events. As I said, we hope to have one on Madagascar coming up. And then also, of course, there's our monthly Emerging Practice webinar series. So thank you all. We will send out the materials to you. We have your email address through the registration, but you can also find this recording and all other previous recordings on our website, which is gbvaor.net. So thanks everyone and have a great afternoon.
Thank you, Jesse and colleagues. Many, many thanks.
Thank you, Jesse.